Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Healthcare du Jour is brought to you by Carroll, the telehealth platform enabling healthcare's digital transformation, helping you care for people within the fabric of their daily lives. Now here's your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Lynn Carroll, Chief Operating Officer at HSBlox. Lynn, welcome to the show.
Hi, Matt. It's good to talk with you today.
So, Lynn, what I always like to do at the beginning of every show is give my guests a chance to provide a little bit more of an introduction in terms of who they are and what they do. So the floor is yours.
Sure. Thanks, Matt. So I've actually been in healthcare, and every time I think about it, I think it's over 20 years, but it's actually been 30 now. And I got my start when I was in high school. I was processing claims for a provider-sponsored health plan, and we were thinking about how to expand the business, and we were primarily doing a lot of things at that time that were in the self-funded, primarily for state-based types of contracts. And then when I was in college, I did some additional work at the same health plan, got to know a lot more about managed care, got to know a lot more about different models of, either risk-bearing or other types of contracts. They weren't called value-based care at the time, and a lot of things were case rates at the time. And so I got started sort of by accident through summer work, and then got into working very heavily with the provider-sponsored plan that I was at after I graduated, and put in a budgeting system. And it went from there into more global types of reimbursement programs before they were, significantly in vogue. And just kind of mushroomed from there, got into the payment side of things within healthcare, and have been in ever since.
It's a very interesting background. So it's kind of what initially drew you into wanting to get into healthcare, and especially with, all that provider-sponsored payment that you were talking about.
Yeah, I wish there was a really great story about it. When you need summer work, you take summer work, and got into just doing some claims processing right at the guts of the operation. The business started to expand. I did some more work there in summer times when I was in college. And after I graduated, I put in a budgeting system, and things started to just kind of grow, started to learn a lot more about different reimbursement models, specifically in the provider-sponsored plan space. So I had a lot of exposure to both the payer and the provider side. And that got me into a whole host of things, early iterations of HIPAA, exchanges of data that were trying to be standardized at the time under the EDI side of things, and eventually got into payments, card processing within healthcare, patient collections, and just kind of moved from there.
Yeah, but it kind of, as you said, absent maybe a bright origin story, I think that gradual evolution and being able to participate in the development is arguably more impactful, because it's, you could see where the foundation was, and not just see it, but you help to build it and grow from there.
Yeah, it's interesting. We had our sort of our origins in a multi-specialty clinic that was partnered with a hospital system. And we sort of replicated that model throughout the Midwest and the upper Midwest to other group practices and more community-based health plan avenues. And the business grew. It was a good business from both, sort of traditional HMO, PPO, POS style plans, good ASO operation as well for self-funders, and got a lot of exposure to employers as well as, state and government entities through that journey.
If you can talk me through a little bit more of that journey in terms of, as you said, talking about taking on some of the risk, and, obviously, as you said, it wasn't called value-based care back then, but just, what did those kind of early iterations of the provider-sponsored plans and the attention to what was likely global care look like?
Yeah, so a lot of the provider-sponsored plans at the time were sort of set up as an answer to Blues penetration and pricing mechanisms in those markets where you had sort of a premier or tertiary, center of care or center of excellence that, drew from, say, a 50-mile radius. And a lot of those organizations serviced or had state and federal employees that lived, near those facilities. And of course, the Blue Cross Blue Shield plans, as well as some of the other national carriers, were in those markets. And so I think it was an answer to how can you kind of capture more of the healthcare dollar, manage it effectively in an integrated environment, and move to, what today would be considered more of a holistic approach to folks. It really wasn't called that back in the day. Some of those models included capitation that included both specialty and primary care. Some of those models were percentage of premium types of models where there was a global percentage of premium shared with a risk-bearing provider at that point in time. And so it was it's often, called, the heady days. I think the heady days probably exist every day. But in those, in that time frame, there were a lot of things that were evolving as more and more provider organizations were looking at how to structure their reimbursement from either insurance or from self-insured payers.
So, and was that maybe to some degree an idea before its time at that point, or were there the mechanisms and tools in place that help to drive success in those models?
Yeah, I like to say a lot of times that, what's old is new again. I think there were a lot of forward-reaching thought processes at the time about how global reimbursement models and, focus on outcomes could drive better, patient experience, could help to, mitigate cost, could help to manage chronic disease. I think some of the challenges at the time were, fee for service is a great business, and fee for service is still a big portion of business for folks today. But I think the view was that as we try to look at a more holistic view of the patient, let's see what global types of reimbursement models can do. I think the challenge were lack of data standards, lack of interoperability. Some would say some of that's still present today. Certainly, we've got more data standards. We're working on the interoperability side of it. And the Cures Act is certainly pushing the envelope that way, particularly as it relates to patient data and the ability to grab my data, share my data, ask for it to be shared, provide consent for how that information is managed in a more longitudinal care team fashion. And so I think there were limitations in terms of how information could be shared. And of course, in the late 90s and early 2000s, internet became more and more prominent. And of course, today is the only thing we really know about how to share information. So I think, a lot of those same concepts are more enabled today than they probably were even 10 years ago at this point in time.
Yeah, so kind of picking up on that piece of the discussion, do you feel more bullish when it comes to value-based arrangements in the current state of healthcare?
Yeah, so you dropped just a little bit there. Matt, could you maybe repeat that particular question?
Sure. I was just asking, given the developments that you were talking about in terms of, increased data standards, more connectivity, although recognizing that interoperability isn't necessarily where it needs to be yet, do you feel more bullish about the opportunity for value-based care and value-based arrangements in the current, kind of healthcare environment as opposed to where it was previously?
Well, I think there's evidence that things continue to move, maybe not as rapidly as either we might like or as, it might be hoped. But I tend to think of things across the continuum where I always put fee for service on the left side of a whiteboard. And I think about pay for performance and more incentive-based programs in the middle, P for P types of programs, and then put the more value-based, full, partial risk sharing, up and downside risk sharing on the far right. And when I think about, that continuum going from left to right, fee for service to say full cap or carve out disease specific types of arrangements, it's interesting to think about where we have evolved from a focus on billing types of transactions on the left side and how many transactions can I bill, to looking at, well, what is the information that I really need to manage under a risk-oriented environment from an outcomes standpoint. That sort of gets you into thinking about where is that data? Is it siloed even within my own organization? Not to mention, are there pieces that are present in the home from patient-based feedback, recurring patient feedback, in-home monitoring and IoT types of approaches to understand status change? So if you've got chronic disease patients, you get below a population health scenario and you get directly into precision health, which is very patient specific and potentially, depending upon the technologies deployed, more real time. And so the advantage, obviously, of a more real-time approach from a data collection standpoint is an easier ability to understand if there's been a change and take action before you end up with a hospitalization or unneeded use of ER. So when you talk about stratifying a population, understanding where the risks lie, and then trying to prospectively address those factors to keep folks healthy and at home and not unnecessarily have admissions. And certainly if there are acute incidents post-discharge, make sure that the patient recovers appropriately and doesn't require a readmission, for example.
And kind of thinking about all those aspects that you just mentioned, what are some of the operational features or tools that are needed to actually put what you're talking into practice? Because it's I think a pretty significant shift from, as you were talking about, that transactional nature of how can I just do more services or see more people?
Yeah, I think when you think about a volume-based environment or a fee-for-service type of an environment, you're thinking about a series of different services happening sort of somewhat in silo fashion. There is some care coordination along the referral side. There's some care management and utilization management components. There are population health disease management components. But the reality is the data is still fairly siloed. In that longitudinal scenario of understanding what all is going on with the patient and trying to capture that in a more longitudinal health record is certainly going to be a big part of what's going to need to happen to deliver on the promise of a value-based environment. And when you think about that transition point, it requires certainly sophisticated technology where it's available on the API and interoperability, FHIR standards, HL7 side of the equation. But there's a lot of valuable data that's not in those types of transactions. There's unstructured data. There is data in non-medical entities like community-based organizations and social service agencies that we need to digitize and get into the fabric of the system so that we have that up-to-date and holistic picture of the patient.
And kind of, as you said, creating that more holistic picture of the patient, are there particular building blocks that you feel need to be put into place before others?
Yeah, so I think when I think about a value-based arrangement, I think about who the stakeholders are, certainly the patient, but what is the care team or the continuum of care that's going to be involved? So you think about, particular chronic diseases, are there dietary considerations? Are there simple challenges with regard to transportation? You see a lot of movement to in-home dialysis as an example, versus relying on transport of the patient to a dialysis center. So some of these are also infrastructure needs for how do you effectively communicate not only with the patient, but with those responsible for caregiving, which might be folks in the home, they might be folks in the neighborhood or in community health centers that have traditionally been more fringe participants with regard to these types of programs. And so we can, think all we want to about the stakeholders and the standards of data exchange, but the reality is a good portion of those stakeholders aren't doing FHIR HL7 transactions. They're not doing EDI, but what they do have is remote devices in a number of the situations. I work in downtown Atlanta here on weekends with Meals on Wheels, and one of the things that you notice when you just deliver meals is all the other factors that play into things. But one thing that has been in common is the vast majority of the homes that I'm in do have digital communication. One or more of the individuals in the home do have a smartphone in the vast majority of the cases. And so when you think about community-based organizations, caregivers that are in the home, and you think about, a good portion of the patients, I'm not going to say all patients have a digital smartphone, but you have the ability to capture data where people are at and use the technologies that they have. So getting that information into a traditional care management infrastructure and workflow is a big part of enabling some of these programs. And that's an area that I think is going to continue to evolve. We saw a lot of that happen with the telehealth side of things during the pandemic. We've seen more activity in the community at the street level with regard to housing security, with regard to different programs on the food security side of the equation. We've seen educational programs for those about their chronic condition that have English as a second language, which is another potential barrier to addressing needs of those with regard to their own healthcare situation.
Yeah, no, and I'm very intrigued by kind of the focus you're placing on, the recognition that a lot of individuals have access to digital communication tools, whether it be a smartphone or something similar in their daily lives, and figuring out how to incorporate that into the care delivery. And also for those of you just joining, I'm talking with Lynn Carroll from HSBlox, talking about value-based care and the shifting ways of operation to help enable it. But again, thinking about that digital interaction that you were talking about, do you see the kind of the hurdles there more on the care team side, on the individual side, or kind of what do you think is needed to help bridge that gap and really get everybody used to consistently using those opportunities?
Well, I think it's sort of twofold, which is that in the homes where digital communication may not be available, it's got to get there, right? And so you'll see some of the initiatives going on in the direct primary care space, as well as home-based solutions on the home health and activities with daily living assistance scenarios. You'll see, notepads and smartphones present to be able to capture information, what we would refer to as at the edge. Some of those are survey and assessment types of tools to try to assess what's happening with the patient in the home or in the community or where they're at on a physical location side of the equation. And so I think in those scenarios, you're talking about the care team members actually bringing some of that technology in where it's not present. In other scenarios, right, where that technology is present at the patient level, have the ability to appropriately message and educate with more real-time and up-to-date data. Part of this is about how does that engagement and interaction occur, particularly for those that have a chronic disease, and how do you educate the patient on that chronic disease and keep them up to date with their latest testing issues and different measurements that are being scored to understand, has the risk increased or not, which becomes an important part. If I'm a provider organization, for example, and I'm going to go at risk for outcomes, I want to know as quickly as possible if there has been a change in status. And so I think the digital side of it is the frontier of being able to understand as up to minute as possible, has there been a change and does an action need to be taken before things get worse?
Yeah, and kind of seeing that as the frontier for enabling, as you said, real-time understanding of what's happening within an individual's daily life. Do you think the tools currently exist to support that? And if they do, are they being appropriately implemented, or do we still need kind of refinement and evolution of what's available?
I think the simplest answer is we have digital tools and we have digital communication ability. I think the challenge is how can we use those tools effectively and ensure that there's access in the home and at the patient level for as much of the population as possible. When I think about the exchange of that data, there are still challenges with regard to the multitude of devices that are out there, a multitude of applications, how that information is captured, stored, and then ultimately shared usually still requires some form of translation and transformation to be able to get it into a data set that can then be utilized for population management, analytics, and ultimately risk stratification. Because, of course, the goal is we want to invest resources where they're needed and avoid using resources when they're not. And a lot of this gets into how do you keep the patient population, particularly those with one or more chronic diseases, under control and managed so that we don't have unnecessary, acute incidents.
Yeah, no, I think that's a fair point. As you said, trying to avoid the acute incident, it's, I think everyone, if you ask them from a common sense perspective, is that your goal? And I suspect that almost everyone would say yes, because no one wants to have an emergency or have a significant issue arise. But then kind of as you're suggesting, it's, how do you drive the right level of engagement and also ensure that you're obtaining actionable data that can allow you to become proactive?
Yeah. And, I think, if you look at where health plans, employers, and provider organizations are deploying resources, there's a lot of buzz about individualized care, patient experience, and patient education and engagement scenarios to try to make sure that we take advantage of getting as much information out in real time and as much information back in real time to avoid these catastrophic incidents if we can take action. So much of things in the healthcare system have traditionally been fairly reactionary or retrospective in nature versus what I would consider to be more precision, i.e. at the individual level to say, yes, we know specifically you, Matt, have this particular chronic disease. You also have a complicating factor in the home that you're alone most of the time and don't have transportation. So if we even want to manage your condition, we need to figure out a way to be able to either get to you or bring you to us because you lack transportation, as an example.
Yeah, and I think it's kind of, as you said, is bring a multitude of factors together. And then I think on the care delivery side, it's also determining how best to utilize, personnel resources, because as you're incorporating more of the remote engagement and remote monitoring capabilities, someone has to be reviewing the data. You can't just have it come in, and you have to balance that against, you still have people coming into the office. So it's really developing a lot of new workflows.
Sure. And I think, how much data is too much data, right? So you get a lot of data, but you also get a lot of noise. And so I think, you see organizations taking the approach to apply newer technologies on the machine learning and natural language processing side to be able to pull out of this plethora of data, well, what's really important? What are those sentinel indicators that help us to avoid these acute incidents and help to manage chronic disease on an ongoing basis? And that noise factor is what, I think everybody's sort of after, is how do I reduce that and get to the meat of the equation so that I can really address in a timely fashion what needs to be taken care of. Because, too much data or data that's, a huge wave of data that can't be parsed apart and get down to the basics quickly is not real-time data.
Yeah, no, and I think that's a really important point. As you said, you can't just flood in the data. You actually have to show some type of analysis or impact of it. If you're just getting all the raw data, then no one's going to want to or really have the ability to sort through all of it. But believe it or not, we're already almost at the end of our time. So I want to kind of ask one final question.
Sure.
Which is, what do you have as a bold prediction for where value-based care will go through the course of 2022?
Well, I think a couple things. We're going to continue to see evolution of employers demanding, effective programs to manage costs and improve health, as well as, maintain the health of those with chronic disease. Ultimately, it's a significant amount of the funding coming from employers, and I don't just mean on the self-funded side. They're paying premiums on the fully insured side of the equation. And I think the accountability aspect that you see out there is going to continue to evolve, where more on the self-funded side are going to continue to do direct contracting. On the primary care side, I think the relationships between those primary care entities and some of the community and social service agencies will continue to evolve. And I think we'll see continued push toward more value-based programs, which CMS is pushing heavily right now.
And I think a lot of different pieces to keep an eye on. But as I said, believe it or not, we are already out of time. I want to thank my guest, Lynn Carroll, for a great conversation today. Thanks,
Matt. It's good to talk with you.
And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.